Hello, everyone, and thank you for joining today's webinar, The Silver Lining of COVID-19, Accelerate Innovation on the Road to Transformation. This webinar is sponsored by Medical Informatics Corp. Medical Informatics Corp, MIC, is a software-based monitoring and analytics company. MIC's FDA-cleared sickbay platform unlocks and processes all patient data from the bedside to enable flexible, vendor-agnostic, remote monitoring and real patient analytics at scale. MIC and Intel are working together to fund the rapid deployment of sickbay to help hospitals expand ICU bed and staff capacity to support the next COVID-19. I'm Sean Edwards, Director of Marketing Ops at World Congress, and I'll be introducing today's webinar. Before we start, just a couple of housekeeping items. This is a panel discussion. There'll be no formal slide deck for today's session. If you're having any problems viewing the discussion or encounter any technical difficulties, please use your chat box and send a question directly to me, the host, and we'll try to help you. Second, I'd like to explain how we're handling questions. Due to the number of attendees, participant lines are muted. However, if you'd like to submit a question for presenters, please do so using the Q&A feature at the bottom of your screen. Please submit your questions to all panelists. We will also be running a number of polls during today's session to shape our conversation, so please be sure to participate. Finally, please do feel free to contact our presenters with any additional questions. Please note that this webinar will be recorded. You'll receive an email with a link to the video so that you can view it again. I would now like to introduce our moderator, Ferris Taylor, who will then introduce our other panelists. Ferris W. Taylor is Executive Director of the Healthcare Executive Group, HCEG, a national network of thought leaders focused on innovation and technology to grow, share, and reshape healthcare. Prior to becoming Executive Director, Taylor served on the Board of Directors for HCEG as the COO of Arches Health Plan in Salt Lake City, Utah. Now, without further ado, here is our moderator, Ferris Taylor.
Thank you, Sean, and thanks to all of you for joining us. And normally I would say bienvenido a Cinco de Mayo, but that doesn't seem quite appropriate. More appropriate is to really salute those of you on the front line that are working to keep us safe and well, and we do thank you. It is also Public Service Recognition Week, so we thank all of those providing public service in this crisis that we're facing. Today's topic couldn't be more timely. And as Sean said, is there a silver lining in COVID-19? And could it accelerate the innovation that is so desperately needed in healthcare? Necessity is said to be the mother of invention, and we're seeing innovation in lots of areas in weeks and months right now that typically would have taken years and decades. So I'll briefly introduce our panelists and then ask each of them to start our discussion by sharing what has changed in innovation in their organization in the last couple of months and why. So we're looking on this panel today to share some real world examples and experience. As Sean mentioned, we have with us Emma Faust, PhD and MDA, an executive officer of Medical Informatics Corp, working across the country, and she'll be able to share a broad set of experiences on innovation in healthcare. We also have Peter King, Vice President and Chief Innovation Officer at SCL Health in Colorado, and Michelle Stansberry, VP of IT Innovation at Houston Methodist. And finally, Dan Duran, MD and Chief Innovation Officer of LifeBridge Health in Baltimore. So maybe we start out in that order. Emma, lead us off and tell us what you're seeing nationally from an innovation point of view, and then we'll let you sort of capstone this at the end as well.
Well, Ferris, as you know, we enable remote monitoring workflows and patient surveillance in hospitals around the country. And as you can imagine, with the emergence of COVID, it has sort of made hospitals sort of acutely look at different telehealth, different options out there, whether that's external to the hospital, trying to connect physicians with patients that can't come into hospitals, and looking at how they can operationalize different remote monitoring workflows within the hospital. I think, you'll see this across the panel here, but I think we've all seen a sort of a pressure put on the innovation arms of institutions to think out of the box of how do we meet these sort of immediate needs that have really put time pressures that haven't been experienced in our sort of the living memory of, in terms of looking at how to organize staff, looking at how to organize resources, dealing with things like people being in quarantine, changing workflows on the fly within the organizations. So I think it's really shaken a lot of things up, but I don't necessarily think hospitals have changed the core of what they're trying to do, which is deliver a high quality of care with the resources they have at hand. And so, that's sort of where we've seen a lot of shifts, just a focus on innovation, a focus on how to get things operational as fast as possible.
Terrific. Peter?
Yes, so SEL Health, a little about it, it's an 8-hospital community health system located in 2 different states, Colorado and Montana primarily. And when it comes to innovation, what the innovation arm at SEL does is identify, initiate, deploy high-value ventures that improve access and experience. In particular, finding a patient and keeping that patient. I think a lot, or I can only speak for myself, but I think in general, I see a lot of innovations arms before COVID was really looking at a 3 pressures, right? Alignment of incentives, market competition, and consumerism. And I think what COVID has done, especially on the consumerism front, if we thought it might slow drip to your market in 3 to 5 years, COVID overnight has changed how consumers are going to access and engage health systems. And that's right in front of our door now. I think the second thing that I've seen is just from an innovations venture side, a lot of things that in particular we'll probably be looking at virtual health, but it was primarily it wasn't as widespread as we see it today. And I think one of the important roles of innovation has been being able to put these things out there. So when, say, COVID did hit, if you had at least some foundation, you were able to build off that. If you did not have those diversification of portfolio efforts, and you're responding COVID from a blank slate, you're really against the wall. And I think overall, from a cultural standpoint, is that one, our ability as a health systems to be agile and make speedy decisions, but at the same time, really now understand the importance of innovation and diversifying your approaches.
Terrific. Michelle, how's Houston Methodist?
Sure. Well, Houston Methodist is a multi-hospital system here in the Texas Medical Center and our surrounding community. And we also have a research institute and a LTAC unit. But, I agree with Peter and kind of on the innovation side. I think before COVID, everybody was really focused in on kind of their innovation initiatives, really around consumerism, patient access, providing patients, where they want care, how they want it, and being able to look at what as the hospitals could be able to do to provide that access for the patients. And part of that was virtual care. And we were working on virtual care. And, we had created our own technology hub about 1.5 years ago. It came into, in our minds. It opened up here late last year. And what was interesting for us, and really this whole virtual care, is that we were just kind of starting into it, started in our own employees and then adopted it out with our patients, but hadn't seen wide adoption yet, even though we were trying. And I would say, in some of our clinicians, they weren't quite sure. They liked seeing the patients, face to face, but all of a sudden COVID hit. And, what we've really seen is that it's just exploded across our organization, and not just from, virtual urgent care or virtual visits from a patient, but also our virtual ICU. We started off with one of our hospitals in using the sick bay, the MIC sick bay product, and it just has been such tremendous benefit for us that, we are continuing to expand it. And so, from our innovation perspective, what we've seen is that the initiatives that we were doing, that maybe we were getting slow adoption or we were just doing pilots, really, it's just kind of exploded across our organization now so that we could be able to help take care of these patients. I will tell you, one of the other ones that was truly beneficial for us, especially from a patient experience, was being able to use technology from the iPads, and giving them so that patients could connect with their family members. Because as you all know, family members couldn't go into these rooms to be able to communicate with their patients. And so we wanted them to be able to have that flexibility, not only so from communicating with their physicians, but being able to get connected to their family members as well. So, I would say it's, innovation just helped us be able to quickly move into a realm that helped us be able to take care of these patients effectively.
Terrific. Dan, start us off from LifeBridge.
Sure, I would echo most of what
Can
Peter
we
and
hear
Michelle
you?
also said. There have kind of been three movements to this. I mean, in the pre-COVID, are you able to hear me? Can you hear me?
Yeah, we can hear you. Yeah.
Are you?
Yes.
You do? Okay, I'm sorry. In the pre-COVID era, I would say it was characterized by a few early implementers on the physician side that were interested in telehealth, and often there was either something very particular about their specialty or they personally wanted to be able to work remotely. And obviously, the overall subscribership to telehealth was probably less than what consumers wanted, but consumers also, to be fair, in our geography, weren't necessarily clamoring for it primarily. Over the last 2 months, as Michelle and Peter have noted, all that's changed, and now we're kind of being thrust into this mode where the operators need it. And it's really wonderful from a change management and innovation perspective, because now you're not pushing it and you're not keeping people informed and checking in on them with something that they don't have bandwidth for. Now they're pulling for it. And as long as you have the resources and you've thought out, as Peter referenced, the foundation for providing that in a distributed fashion, then you're in pretty good shape. What I'm even more excited about is what comes next. And I think folks will want more of it. It's kind of like, I would liken telehealth in this context to the Dr. Seuss book of Green Eggs and Ham, and it's like, wow, you've been asking me about this, popping around here, asking me if I want it over and over again. And there was always some reason I didn't want it, but now I have to eat it. I have to taste it. I really like this. All of a sudden, the operator, the clinician's mind starts to explode with all the new ways this could be used, which frankly is innovation at its best. When the operator innovates, they're able to go so much farther often than the innovator is able to do. So a couple things around that. The innovation groups need to be really hoping that the operators run with it and willing to step back, but also willing to step back in to help them navigate some of the issues. And where we're starting to get brought in even early on is whether, rather than think of things in terms of bricks and mortar care versus virtual care, we are instead thinking about the entirety of care and where in the coming years and months does it make sense to unbundle that care into physical and virtual components. And in the past, those conversations had a very different character to them, where the operators were like, well, what are you going to take away from me and put in that virtual bucket, which they viewed as a bucket where they were more fungible and wouldn't have as much ownership over it. And now I think it's because they're operating in it and operating quite well, they feel the ownership, and it's letting them rethink healthcare. So I think we're going to see an explosion of innovation over the next 5 years that will be in some really interesting directions. And there's no question there will be some friction and headwinds with the existing bricks and mortar footprint of health systems. But there's also, I think, no stopping it at this point.
Interesting that all four of you have talked about the virtual, the remote aspects of this. But in fact, telehealth has been out in the marketplace for 15 years. I've seen numbers that say, telehealth visits are up 50%, but I sense in this conversation that this virtual care aspect in each of your organizations has changed much more dramatically than that. Is that the case for the three of you that are working day in and day out in the health system environment? Is it 50% or is it 100% or 500%?
It is many.
Peter, Michelle,
LifeBridge,
Dan?
No,
Go
I
ahead,
would
Dan.
just say
several
it's-
thousand percent.
yeah.
Several thousand%.
Yeah, so at
Correct.
Houston Methodist, I'll just kind of give you a gauge. I mean, prior to COVID, I would say we were having on a monthly average, maybe anywhere from 18 to 2,000 visits. Since March 9th, when this kind of all started with us and now our virtual visit, we have done over 101,000 virtual visits. So as you can see, the average on a monthly basis or on a daily basis has, yes, just expanded exponentially of what we were previously doing before. I mean, in the first week of when this happened and we knew we were going to have to train physicians, we just changed our whole technology hub so that we could quickly and on, virtually also to be able to train over 700 and something physicians to be able to handle and do virtual care, which they weren't used to doing before. So it is definitely just exploded.
I would add that we'll probably see it across every health system, the thousands of percents of increase of usage. I think, Ferris, going to the future or the next normal or the new normal, I think there's going to be two things that we got to consider how far the pendulum might swing back, because I think it's a business model question. I think first will be around how confident are the physicians and the patients to have a seamless experience given that avenue. Because currently, we did train up hundreds of our providers, but they may have slogged through it, right? So in the future, what does that look like? How seamless can it be? And then from there, from the virtual offerings, I think that's going to be virtual health is going to be one thing underneath what I think it's more commonly known as a digital front door to address all things of consumerism and seamless experience. And so it's how far we could keep confidence with our providers and their patients, and then build the business models and the KPIs to reach business metrics under a digital front door modality.
I think what we've seen is that across sort of the life of our company is that technology is a tool, right? It is not the solution to one big problem. It can fill the gaps and augment your workforce. And so when we look at how the deployments have sort of changed and shifted, really I look at it as something where you introduce a technology, and even if you're under less than ideal situations in terms of having to do a massive rollout, people, if they're open to learning about the new technology, they embrace using it because they have an immediate need. What I often see is this idea that it then fills the gaps. In other words, if it reduces the friction or reduces a problem that existed before, people are going to continue to use it, right? They're going to continue to find value in something if you are using a tool appropriate to drive value, right?
Love the digital front door and the fact that, the 21st century will be known as the digital century. And in many ways, so much of healthcare has, until COVID-19, has remained kind of back in the 20th century with our fax machines and our, I mean, that was digital technology, right? Fax machines and like that. Michelle, you've mentioned a couple of times, and I think you're calling it an innovation hub. I saw an article yesterday, I think you sent it, I don't know if World Healthcare Congress can get the attendees a copy of it, but describe that a little bit, and then Peter and Dan, share what your organizations had in place or had sort of as the foundation to deal with a sudden emphasis on innovation. Let's start with you, Michelle.
Sure. I will tell you, probably about a year and a half ago, we just had this idea that, we really wanted to have a space where it is that we could, just have this living, breathing space where we could look at new technology, bring new technology in, to be able to help facilitate how we can better engage our patients, how could we better engage our clinicians. As everyone knows, looking at EHRs, it kind of got us away. The physicians and clinicians got them away from being in front of the patients. So we really wanted this space to be able to create and have the opportunity to bring this new digital technology in that would help our clinicians come in and be able to see what was available. So we created the home of the future, the clinic of the future, an inpatient room of the future, and also a virtual reality room so that, we could showcase this new technology that would help clinicians be able to see it real time without necessarily having to install it in some clinic as a pilot. And then from that, it was easy enough for, if we believed it was value added to the organization, then we could expand it across. Also, as part of this technology hub, the other piece was half of that space would be used as space for our vendor partners. So if they wanted to come in and help co-develop something with us, they would have a space in a real world live environment that had the applications that we're using to help do that co-development with. So it really helped us, as I said, kind of moving forward, having these different rooms of the future. I will tell you, our clinic of the future, we were really focused on ambient listening and how that would work. And so it was helpful for a clinician if they wanted to come in and see what that could do. It was right there. And that's what the space was all about.
Terrific. And Haritha just confirmed it is on the website for those of you participating with us today. It's a great description of Houston Methodist being out in front of that. Peter and Dan.
Let me just add, if I could add one more thing, I would be able to tell. We have had many, many tours come through that space. Anyone's interested in wanting to have a private tour or come and see, all they need to do is contact us. It is within the hospital, and that's one thing that we found that was truly beneficial as well, because trying to get clinicians away from the hospital to go see something that was innovative, usually they didn't have time to do it. But if all they had to do was go down a floor or 2 floors, they were more than willing to come and take a look at it.
Terrific. Peter, Dan, what were your organizations doing before that set the table for this increased demand on new solutions?
Well, from SEL, one of the I think strengths that SEL's size has is it's very conducive to get things done. Sometimes I think we're in the Goldilocks size of health systems to be able to pull off enterprise initiatives, not just little smatterings. And from the innovation team, in 3 years' time, we did over a dozen enterprise initiatives overall. Including virtual health to the lifts to name it, right? What we were on and we're still on the road to is if you look at these initiatives, what you have to do, what I think in terms of innovation, it's not so much about invention, but about seamless integration between these initiatives. And we're on that road to create that digital front door to make it a frictionless and seamless experience. And so that's the work that SEL has been, the journey that we've been on, and we're more than likely accelerating. I think if I had to say pre-COVID times in terms of innovation officers, the metaphor my team usually uses is when it came to innovation before COVID, it was great buzzword, cool name, but it was like a salmon swimming upstream, right? It looks beautiful, but it's really hard work to get it done. And now I think the emphasis of accelerating that type of work is going to be needed. And I think we got to be careful of what we ask for, because overnight, I think my colleagues would agree, if you had all of this capability currently today, what you have today, if you had this a year or 2 years before, you could really differentiate yourself in the market. And that would be a dream. Now what we're going to have to, I think, and it's good, that the rise of competition from all health systems, including other market competitors, are going to push us to say, how will you keep pace with innovation? And so I think there's things that if your health system has been investing in innovation, it's going to pay off dividends and manyfold in the future. Moving forward to the next or new normal, I think we got to actually stay on top of it.
Terrific. Dan? We're not hearing you. Off mute.
Sorry.
There you go.
0 for 2 so far. At LifeBridge, innovation is structured as innovation and research, and it has 5 domains that I'll just really quickly go through so you can understand the scope. and it's been in existence for about 2 years. So innovation is the way, the ability to do new things well. And as Peter referenced, in many markets, that is going to give you a competitive edge. I think in our market, being right next to Johns Hopkins, which is an international brand, as well as some other really strong, large health systems that are bigger than us locally, like MedStar and University of Maryland, we as a 5-hospital system view innovation as kind of table stakes to survive, and so it'd be great to win more market share with it. But if we can't do it well, we have real concerns about the future. So that's why we built it. And there are 5 domains. The first domain is really what most people call biomedical research. I mean, this is innovation from within medicine. So things like gene therapy or diagnostics, et cetera. So the research division falls entirely within innovation, which is different from most health systems, but also a feature of the fact that we're fairly small. And in most universities, research is totally separate, or innovation is an institute within research, and it's actually reversed at LifeBridge. The second pillar is around digital health and things like the digital front door, and also AI and home monitoring and distributed listening and all those types of things. And the reason we separate that out is this is largely speaking innovation that is already percolating through the rest of society that is coming into healthcare. So there's sort of innovation endogenous to healthcare that we consider to be research. And the second piece is the exogenous innovations, largely digital, coming into healthcare. Then there are 2 pillars that have to do with the flow of funds. So one is value-based contracting, that we aren't the only group involved there, but we actually are quite involved in value-based contracting, because many innovations and new things to do could have been done for many years, but weren't because of fee-for-service. And so there's a very important tie to the way that you get paid. And as you develop relationships with payers and think about healthcare differently and get more access to the premium dollar, you can often fund a lot of things that you couldn't do before. The fourth has to do with funds flow out of our health system, and that is a venture fund that we have within innovation. And the 5th pillar is just, and I think some folks referenced it here, innovation as a core capability, the ability for any and all to innovate, which you need to keep fresh and you need to stimulate and catalyze some of the dangers. And Sachin Jain, who's now CEO at CareMore, he was formerly Chief Innovation Officer for Merck Pharmaceuticals earlier in his career. And he wrote a pretty famous article about how innovation dies when you have a Chief Innovation Officer. So I really made sure when I built this up that we had that 5th pillar, because I want innovation, and I think we should all want centralized innovation groups to be viewed as promoting innovation rather than stifling it and forcing it through some sort of central corridor.
Absolutely.
I really think that core capability is so critical. I think what's important to distinguish is that innovation or an innovation mindset built into an organization infrastructure is not a natural thing right off the bat. I mean, there are usually innovative people, innovative pockets, but to formalize an innovation mindset, build the structure within the organization to facilitate that innovation, and then ultimately take what you learn after, iterating and working out what works for your institution and then operationalize it. That really is the holy grail. I think it is distinct from what you typically see in organizations, traditional organizations, where you have your balance of plant that's set aside that is really focused on doing things reliably, efficiently, and rinse and repeating again and again and again, right? That's what often operations becomes in a larger organization. And so I really, Dan, that concept of building innovation as a core component is so critical for people trying to get into this or thinking that this might be something good for their organization.
And we're certainly seeing a lot of external involvement or external to the traditional healthcare environment in the innovation here in the short term. We will be taking questions at the end, and I know Sean has prompted you to put your questions in, but there was one that came up, Dan, that I think you touched on that I think we should take right now. And it's from Patricia, and it says, how have payers, reimbursers kept up with this shift? For now, we have waivers and emergency orders that allow telehealth. Will these remain, or will we return to pre-COVID rules? If this happens, what then? And really at the heart of this, is this sustainable where, especially the reimbursement, the digital front door doesn't have a pricing mechanism around it right now. We just opened the front door. So what are your perspectives on that question from Patricia?
So
Sure,
this
Go
is Michelle. I mean, I would just speak up to be able to say that's the magic question we're all trying to get answered today, right? I mean, virtual care, telehealth, it's not going away. Yeah, I think you're going to see this has become the new norm. But how is it going to get reimbursed? What is the government going to do? What are the payers going to do? Previously, before, they weren't doing much, if they were doing anything. And so, it is going to be critical that I think the payers and the government really address moving forward here very quickly. How are they going to, do the reimbursement for, institutions and physicians who are providing telehealth to their overall patients?
Dan?
Sure. I came off on mute on my own that time. I'm very proud of it. So I agree with everything Michelle is saying. I think what I viewed as the historical reticence of these payers to actually pay for a lot of these things, and especially it's true of Medicare, isn't that they don't realize the value. It's that I think we're very, very, very scared about overutilization. So telehealth works really, really well in a value-based environment. And the reason it works so well is you're essentially engineering out the cost over time of the footprint. If you have a provider organization that's on value-based contracts and it has the ability to exit bricks and mortar establishments that it either leases or sell them off if it owns them, and it's suddenly providing tech-enabled services through virtual care, you can very quickly, the usual business operations will help ensure that system tends towards maximal efficiency and value. In other words, that consumers get what they're looking for because they'll shop for it, and also because they're on the hook for the whole premium dollar, the provider won't overutilize. I think what the payers have been historically worried about is that if you start reimbursing a lot of these fee-for-service encounters on tele, but the provider organizations continue to have their other cash cows at the same level, then they feel like they just wind up paying for more. And unless they get profoundly better outcomes, they are then delivering lower value for society and creating exactly the kind of issues that payers exist to avoid, which is the amortization of healthcare and the control of the expense while getting the same outcomes. So I see historically that both sides, I think, have come at this with pure intentions. And I think now that we're doing it differently, and payers have been very involved in the short-term steps, it opens the door to these other considerations. But ultimately, I think without value-based contracts, then it will become a startup versus incumbent battle, which from a health system perspective, I don't really want to see. So I talked before about how you might unbundle care into virtual and non-virtual. I think there'll be a lot of, if there's a lot of competition for the virtual, but you still need the bricks and mortar sometimes, that could create some encounters just get left to some organizations, which could be problematic. So I don't think it'll be a smooth glide path. This will be bumpy. And the single biggest thing I think is this: patients and people and voters, the citizenry, if they like this taste of virtual health, they're going to need to clamor for more, because these things aren't just going to figure themselves out. They're going to require pressure from society and from employers in particular.
And Pierre, you had mentioned alignment of incentives, and I think Patricia's question is right focused there. What do you see?
Yeah, I think historically what you saw, I think is a problem of incentives and aligning it so we deliver on the quadruple aim has been around incentives. If we think about the American healthcare paradox, that we spend more per capita and we're getting okay results compared to industrialized nations, why is that? And why has there been a resistance to, giving more access and more convenient and lower priced modalities? It was probably something from the fee-for-service world. It drove it. I do think in behavioral economics terms, when it comes to this, that it drives behavior. And I think what we're going to see, going back to the question, there might be two things, right? The immediacy is, will the genie be put back in the bottle? Because if we say just currently right now, let's just take telehealth, because I think COVID is bringing all sorts of great innovations, but we're focusing a lot on telehealth. If we just say it's being paid on parity, I think it's going to continue. Will they bring it back, the genie back in the bottle? To what extent? I think going back to behavioral economics, and if we still keep in the fee-for-service world, you'll see some pullback because of that. Now, the other stream that I think about is, you could look at the economic pressures about the stimulus packages. We thought Medicare was going to go, depletion of funds in 2028. Now it's in 2022 or something. Is the march towards value-based care going to expedite? And so I think in a world that it's more capitated, or in the value-based world, you're going to see a lot more innovations come out. If we swing it back into the fee-for-service world and we start putting the genie back in the bottle, one, I'm not sure that's going to be the best way, but two, it's going to drive behaviors.
It's very interesting. I headed up a medical consulting practice for the strategic pricing group, which is now owned by Deloitte and does the pricing work for Deloitte. And clear back in 2002, we did our first pricing study, and I think there was a flaw in that study. The premise was, well, a virtual consult isn't of the same quality of a face-to-face, and so it was priced significantly less. But from a consumer's perspective, and especially today, which is probably part of the reason, the providers have come on board, but the consumers are not wanting to go to the doctor's office. If you were handicapped, there was a premium that you would be willing to pay to have a virtual consult or have a remote monitoring or something like that. There is a question on telehealth that I'll come back to, but before I do,
Ferris,
please,
can I add something?
Sure.
Can I add something there? I do think there is a little bit of a fallacy for the idea of comparing a one-to-one replacement of things. I think that's where you go down. If you go down that path, you do start to have problems around the reimbursement models. I think from our perspective, what we've seen is when you start to look at your underlying infrastructure, that your technology infrastructure you're putting in as an organization, the way you build flexibility into that infrastructure allows you to layer on different types of functionality that go above and beyond one use case. And I think if you select technologies or solutions based on a one-to-one replacement, you're going to be in trouble in the long run. When I look at a lot of this sort of from the data perspective and looking at modern technologies in other industries, right? When you unlock the data and you start to challenge how that data is used on those sort of one-to-one use cases, you start to unlock new ways to leverage that data for organizational efficiency, for better revenue capture, for ways to innovate within your organization on a lot of different levels. And so what I think I would challenge people to think about is not just, telehealth or remote monitoring solutions replacing existing the way standard of care is. It's there to augment and integrate into your workflows so that, just like Dan was saying, you can sort of seamlessly develop a patient engagement strategy that has both physical and in-person components to and virtual components to it. But then there's another layer there too that because we play in the space a lot, it's predictive analytics, it's automated event detection, it's trying to do more with less and making your hospital more efficient overall. So I just want to throw that out there because I think that's where actually a lot of value has yet to been unlocked in this area, and it's sitting there waiting, I guess is my point.
Great. We haven't, interestingly, on the innovation discussion, we haven't talked about much of the external entrants. I know, Dan, you had mentioned that Under Armour was sewing masks in Maryland, and GM is making ventilators, and Apple and Google have teamed up, and several of you referred to the iPads, virtual ICUs, and giving the patient an iPad to connect with their family members where they can't connect. We haven't talked about drive-in testing sites. Any comments or perspectives on outside of your own hospital system? What are the innovations that you see out there that may have staying power beyond COVID-19?
Sure, I'll take part of this one. I mean, a lot of the things you're referencing there have to do with all of the market dysfunction that arose out of supply chain disruptions, which was not, a medical specific thing, but because after the stay-at-home orders kicked in, medicine was sort of one of the only businesses really up and operating. And then the famous example, along with masks and gowns, and Under Armour is a local group, but folks like Brooks Brothers and Nordstrom's have also been involved in sort of getting into a part of the industry that they weren't normally in. I think the makers of Givenchy and Yves Saint Laurent, like these fancy perfumes, have been making hand sanitizer, right? And it has echoes of what happened, or we're told happened, back in World War II. I don't think any of us were around, and very few other folks were. But all sorts of different parts of the industries turn their attentions to the war effort, and we've kind of seen that for medicine. So it's interesting. And locally, yeah, Under Armour got involved. I'll just give you a quick story of that innovation story. They wanted to help out, and they started working with lots of different health systems, trying to figure out how to make a mask. And they actually didn't end up selling it. They figured out, because they're fabric people and they think about this type of thing all day, they internally figured out a way to cut a single piece of fabric, which means you can do it way more efficiently, and then fold it into a mask. And they wanted to be able to produce as many masks as they could for the health systems in Baltimore, but they were a little bit bandwidth constrained on their workforce, actually. So where we were able to help at LifeBridge is, we said, we will do the parts that don't involve cutting, because Under Armour has a large global distributed supply chain, and they don't make any of the stuff in Baltimore. They cut some of the material, they do the distributions, but they don't make a lot of it here. So they had their designs team in Portland, I think, from their shoe team, figure out how to cut this piece of material. And then we actually took some furloughed employees and we built a factory, a PPE factory, in the second floor of one of our outpatient buildings that was about to be developed, but it hadn't, so it was nice and open. And we put 90 sewing machines in and folding stations, and we took the process from Under Armour, from the 1 or 2 material science people that had figured out how to fold the masks, and then we had a workforce of 50 to 70 people fold them. And so we've made about 250,000 masks that way. And then we started using the sewing machines for a gown model, where we figured out, we reverse engineered a gown, and made it so that it was the simplest thing possible to sew, so that we could train folks like me who have no sewing experience to be able to do this new thing quickly. And so we built a process around the workforce, right? Again, sort of like not at all the way, it would almost be harder for Under Armour to make clothes that way because they're so experienced, right? It'd be like taking a professional hitter and telling them to use some crazy stance they would never think of using. But in this instance, the workforce to sew is this unskilled labor force. So we had this iterative design, and it sort of unlocked a lot of their effort, even with some of the larger health systems, because those larger health systems were mainly thinking about sourcing in different ways. And because we had thought about what it would take to make our own stuff, and that we were willing to take that unskilled labor part off of it, they just started requiring health systems to do that. And now they've provided millions of pieces of apparel all over the East Coast and all over Baltimore. And if you get masks from Under Armour, you have to fold them. That's part of the deal. But Under Armour will source the material, which is very, very challenging, and they will cut it, which is impossible for a health system to do.
Michelle, I think you mentioned the iPads, virtual ICU, patients. You're on mute.
Have to make sure. It's always just make sure you hit that unmute button. Yeah, it's, one of the things that was very important for us was, just from a patient engagement and, because these patients were, so isolated, their family members couldn't come in to come see them. So what could we do to be able to help facilitate that? And so, we distributed, I think, over 1,200, and I'm sure somebody on my team's going to correct me here in a minute, but, around over 1,200 iPads. And it was one really for those patients, not only to communicate with their family members, but how could we facilitate communication with the clinicians? so that they could talk with them without necessarily always having to go into the room. Because remember, having to go in the room meant having to gown up, really get into that PPE equipment and everything else. And that wasn't always necessary when you just needed to communicate something very quickly with them. So, you know, we worked with our distributors, we worked with Apple, you know, and was able for us to quickly get these iPad devices to get into the rooms. One of the other things that we did as well is your Amazon Echo device. We put those in some of the patient rooms as well. So one, they could play music. They could also do communications with their family members through that way if they needed to. So again, if you stop and think about some of these patients having to be so isolated and not being able to get to see any of their family members or really talk to them as much, we wanted them to not have to feel that isolated and to be able to have that type of communication. So it was very important to us. And, you know, I kind of agree with Dan. It's been amazing to see corporations who've never been involved in healthcare before really step up and try to, you know, only from producing hand sanitizer to masks to other equipment, PPE, some of the other things. You know, it has just been very rewarding to be able to see how overall the community as a whole has come together to be able to help with this pandemic.
Any comments, Peter?
Well, first I was like, so Michelle, now I know who took all the iPads. No, just teasing. We did very similar work. I think one thing that was interesting was, you know, before COVID, what we were working on from the transformation side was operating our 8 hospitals under a command center, like the NASA command center that you find in nuclear to policing to NASA. And you know, the value proposition there was really around access, flow, and quality. Think about the hospital operators on this webinar. How long have you been tackling length of stay, right? And one thing that I think COVID did was that concept of command center. Now, if I say command center, that's how all of our health systems operated during this current 2 months ago and currently, right? That concept of saying, how can you efficiently manage your hospital with innovation or transformation like a command center? I think that that's going to carry through a lot more in health systems as well. And that's coming from an outside practice, outside industry, healthcare industry practice that I think will be embedded more.
Terrific. Our time is flying by. There's a number of good questions here. One that I see is, what metrics will you look for to inform your innovation strategy as you move forward with this pandemic and life beyond the pandemic? What's the success measure?
But I'll go ahead and start and then won't try to take too much time because I know we are running out of time. But, you know, metrics have always been in place, I think, you know, for any type of strategy and even for innovation. And it's going to be different for every institution. The metrics that we're using will not be the same metrics that Peter or probably Daniel or anybody else says. And you have to decide what that is. And so for any innovative solution that we come up with, it has to have overall success metrics. You know, is it patient engagement? Is it truly financial? Is it, you know, some way from a revenue producing? And believe you me, innovation's not going away. And it's, for us, the problems that we're trying to solve in our institution are probably slightly different than what Peter or Daniel trying to solve in theirs. And so that's where I think it's very important, especially now that digital health technology and this whole innovation has just exploded. And you can get really caught up in all the hype and everything that you see, but really keep focused on what it is, the problems that you're trying to solve in your own institution, and then come up with the metrics associated with that to be able to, in our term, succeed fast or fail fast with your innovative solutions.
Others? Dan?
Yeah, absolutely. Agree with everything, as usual, that Michelle said. And, you know, within my, within our system, within LifeBridge, where I'm working, there'll be lots of dashboards and KPIs and board-facing goals, and those will come and go, right, in a way. Any given year, those will very much be what I'm plugged into. But I think during the crisis and the time that comes after it, the internal metric, which I keep within my own mind and within our group, is the number of converts. So these are the number of operators that we've converted to our mindset. The mindset that innovation is essential and that our department is, helping with it. The mindset that the physician or the operator should always just be looking for business as usual, even if they're convinced they're the very best in the world at that one thing. It should probably look different in 5 or 10 years. And then, micro things like around telehealth. So once you get a physician champion or an administrative champion to really drive something, that's when the real magic happens. And that's the converting event in the change management, right? And if we can leap forward from 15% penetration of these concepts to that tipping point of 30 or 35, that's been my long-term goal, which I thought would take a decade, right? But maybe that's been moved up quite a bit. And even on the research side, which could be viewed as separate from innovation in a way, we've never had so many people come to us who don't have a huge pedigree or recent pedigree of doing research publications, who are suddenly really, really interested about science and about advancing medical science and reporting this new thing that they're seeing in COVID and the conditions that are related to COVID. And it's the same thing there. So folks that in the past may have just said, well, I don't really want to do research because I don't get a lot of support to do that and it's just an extra thing. But now we're seeing real passion around that. And if we do our job right, then in a year or two, when COVID dies down, they're going to have other ideas and they're going to want to, they're going to want our help advancing those ideas. I think it's the same thing over and over again. So that's what I keep in my mind is the number of converted individuals that are working with us and want to partner more with us.
Peter, same thing?
Yeah, I think any innovate, this is just my opinion, of course, any innovation needs to be tied to the overall strategic goals of the organization. And from a macro level, I think how COVID is going to reshape even our strategic planning processes, right? So if you're going into budget season in June, July, this has fully disrupted even that, right? You can't just go 3% on top of last year or January. It just doesn't work. And we're going to see a lot of innovation even around strategic planning, budgeting, things like that. I think from the innovation side, though, it really it's a soft metric that I use, but one additional belief I have is to be a good innovator, you have to be a great operator, and you got to get things at scale, because you could do a lot, and that's not bad to do a lot of activity, but I think we should not conflate activity equals progress, right? And so I think for me, it is how many things can we do, but actually get to scale. And then if I had to even dive down more deeply is going back to access and experience, find a patient, keep a patient. How do you acquire a new patient? What does an active patient consumer look like? And what does an engaged patient consumer look like? So I think COVID has really going to open up a lot of different, not only from a strategic planning process, but all the way down to our metrics.
Very good. And there's several questions I want to integrate with a couple of closing comments that I'd ask from each of you in these last few minutes that we have. The one comment is, and you touched on it, how do you bring a cultural shift within health systems to move the needle on innovation? That's we've touched on that, but think about that in the context of two questions. And each of you take some time to answer that. And that is, what does the new abnormal, what does this industry look like when we get on the other side of COVID-19? You mentioned scale, there's lots of components there. And then I think more importantly, and our compliments to World Healthcare Congress and to each of you joining, we have real premier panelists here. But what if you're not down the road from Johns Hopkins and on the leading edge of innovation? What if you're that rural hospital out in Montana that they're just trying to survive? So what is the new world look like, and what advice would you give? What are the 2 or 3 takeaways that you would give all of our audience today as we wrap up this topic? So let me have each of you, as you'd like, think about that. I've thrown a lot out there, and give us your closing comments.
Well, I got a very simple suggestion, and and I'm sure that the others will cover lots of other stuff. But I think one of the key things about doing something new well, whether you're a rural hospital or whether you're in the shadow, I would say, of Johns Hopkins and fighting to be seen around the shadow and not to have the shadow eclipse you, is don't be afraid to ask people who know more about the subject than you do, right? So whether it's to use consultants or use people from other industries that have tackled a similar problem, we've covered numerous times today how other industries have gotten this digital and this consumerism right a little quicker than we have for a variety of structural and cultural reasons. And then we've talked about how essential some of those other industries have been in terms of helping us out over the last 2 months. I never would have known about the effort in Under Armour if I hadn't basically said, I don't really know much about making or running a clothing factory. It looks like I'm going to have to get involved in this. I asked my CEO, can you get me on the phone with some of your friends that own garment factories in China? And it was 2 or 3 phone calls later that I was connected to the Under Armour folks. So for me anyway, maybe there are folks out there that are smart enough to actually be able to just solve every problem. But what I've learned in the innovation space is the most important thing is to figure out the perspectives of those who have come before you or solving it in parallel industries.
I think we have a similar colleague, and I think it's true when it comes to innovation, is you don't get extra points for originality. Just get started, right? And in moments of scarcity, you are the most innovative as well. It is start the journey. Don't overthink it. You might get some things not at scale. Yet you got to start it. I think when we're moving into this new normal, there's going to be a lot of different dynamic pressures that's going to force us to be creative. And so if you're not starting that journey, you do need to at least start.
I agree with everything, of course, that, Dan and Peter have said. One of the things that I have found about healthcare is that we're the most sharing organizations that are out there and are willing to help others no matter what. And so, as you can see from, the panelists here and probably those that are down the street from you, if you don't know where to start, don't know how to start, reach out. I mean, talk with others. They're most willing to share their experience and their pitfalls so that you don't have to go through that same pitfalls that, we have done with ourselves. And I'm just going to touch briefly kind of on the culture that you brought up, Ferris. I mean, I think it's very important in any organization that it starts from the top. And the top is how do you view innovation within your organization? We believe innovation is everyone's responsibility. It's not just this small group of individuals maybe sitting in the Center for Innovation, but you're going to get your best ideas from your staff who are out there working on the front lines. And make it easy, give them away for them to be able to provide those innovative ideas to you. And you're going to find there's going to be some really good ones that are going to come forward.
Emma?
I think one of the most amazing things about working in healthcare is that we're doing it because we're here to save lives and serve other people. And what makes that very powerful and moving is that when you actually sit down to solve a problem, you can generally, if you start there and you start with the core mission of what you're here to do, you can get alignment pretty quickly. And if you can keep the focus on that, you can often overcome any political or sort of internal conflict issues, because I think people are inherently in healthcare to serve others. With that in mind, I think, Peter brought up a great point. It comes down to execution, right? And on entrepreneurship or, business, we talk about, people having great ideas. I think there's a mythos out there that innovation is like coming up with the original idea and then you're the one who came up with it. That has nothing to, at the end of the day, it's all about execution. It's about rolling up your sleeve. It's about breaking down a problem, understanding the use case you're trying to solve for, understanding the resources you have, which may be a lot, may not be as much as you would like. But being creative and innovative is about realistically looking at what's in front of you, leveraging your team, and actually building a plan to get from point A to point B, and then doing that, right? And Michelle's correct. You know, we need leadership support, right? You need people within the organization who are going to have your back and actually see the bigger picture of what the organization is trying to meet and help resource that and support that effort along the way. I think ultimately the new normal is it's going to continue to be a changing, shifting environment over the next 18 months. I think innovation is going to become a core part of strategy for thriving in this environment. And I think organizations are going to have to think about how they can use these resources they have, innovate, and be creative for building a new path forward, and finding that balance between physical and virtual, right? And I guess I would say to hospitals that are out there that aren't versed in the sort of the innovation mindset, it is accessible. You have innovators at your organization. You have the capability, even if it's just small little iterations, even if it's as simple as fixing trash cans in your unit because they're causing too much alarms in the environment, right? Like there are things you can innovate that are not high tech. They're bites you can bite off and really build confidence and build that culture of innovation. So I'd encourage people to start where you can, resource what you can, and then support that and encourage that small wins that build into a larger capability that the organization can take through into the future. So.
Terrific, and we want to thank all four of you as panelists. The underlying message here is don't waste a good crisis. There is a silver lining, and the future is still uncertain, but to all of you, be safe, be well, and I'll turn this back to Sean, and thank you.
Thank you, Ferris. Thanks again to all of our panelists for taking the time to speak today, and thanks to all of you for joining us. Thank you to our sponsor, Medical Informatics Corp., for making today's session possible. Just a reminder, this session has been recorded. You'll receive an email with a link to the video within the next couple of days so that you can view it again. And thanks again to all of you for joining us. Have a great day. And this now concludes today's discussion.
Thank you.
Thank you.